presentation on the work that we have been doing with regards to cervical cancer screening and treatment. I will be building on some of the presentations that we already done yesterday. Great presentations indeed. So LEEP is a procedure that we do in treatment of screen-positive patients. And the goal of LEEP will be to remove all dysplastic cells in accordance to the type of the transformation zone. Based on some international best practice standards, for a type 1 transformation zone, the goal or the desire would be to remove at least 7 millimeters of the cervix. For type 2, you are supposed to go 10 to 15, type 3, 15 to 25 millimeters. And for those with glandular disease, the desire would be to remove the whole transformation zone with more than 10 millimeters of endocervix above the transformation zone. Inadequate excision, especially at the endocervical margins, has been associated with the increased likelihood of recurrence. Nonetheless, samples that go more than 10 millimeters don't necessarily correlate with the reduction in recurrence, and there may be some inadvertent increased risk of spontaneous preterm birth. So on this slide, I am just showing what I described as the city of Harare ecosystem with regards to cervical cancer screening and treatment. So we have clinics there. Like in the city of Harare, we have 22 clinics that are offering cervical cancer screening. Together with that, some of the clinics refer their patients who need to be done at Edith Oberman, and the others they refer to Wilkins Hospital. We also have the central hospitals. They are part of the ecosystem because some of the patients whom we found that they have invasive disease, we then refer them to the central hospital as part of the continuum of care. And also we have laboratory. Specifically, we work with LLETZ for our pathological assessment for all the patients who need, we have been done, we send our specimens to LLETZ. Then the ones which I have labeled there as other are also the private sector. We have facilities that offer cervical cancer screening in the private sector and also non-governmental organizations. So it is against this background that we did set out to evaluate how we are doing our treatments. Basically, we were benchmarking our practice against some of the global best practice standards. We used specifically the British NHS cervical cancer screening standards to compare how we are performing against the British standards. So specifically, we wanted to look at the treatments that we go beyond 7 millimeters, the proportion of women where the loop has been removed as a single loop, the proportion that comes back reporting adequate biopsy, the proportion that come reporting high-grade histology, and also proportion of women treated within 4 weeks of referral with a screen-positive result, and also proportion of women who have been treated who end up having either recurrence or who develop cancer within 12 months. So we conducted a longitudinal cross-sectional study at Wilkins and Edith Oberman Clinic. Basically, our study population was all screen-positive women who were eligible for LEAP. And we looked at data for a 24-month period, that is from January 2023 up to December 2024. And in terms, we were not worried about sampling size, sampling technique, because we took all consecutive cases that had been captured in our electronic data recording system during the study period. So we conducted a desk review. There were 1,618 cases or case notes that had been captured in our data set. We designed a data set. This is a data set that we created on our own using the CGC AppInfo platform. So the data set has variables where we capture the demographic variables, the HIV status. We take the gyn sexual history, the cervical cancer risk profiling. So we collect all this information as the patient will be receiving care. Information to do with the lesion size, the type of procedure that has been done, and also we abstracted lab results from the Lancet portal. That's where we get our results from the Lancet lab result portal. In terms of eligibility criteria, we were looking at patients who were eligible for LEAP. So there must be evidence of dysplasia, no evidence of invasive disease, lesions that cover more than 3/4 of the cervix, lesions that extend into the endocervical canal, and the women were not supposed to be pregnant, and also lesions that were persistent maybe after ablative techniques, that is either cryotherapy or thermocoagulation. So women were advised on follow-up care after the LEAP procedure, and also advised on follow-ups at 6 weeks, 6 months, and 1 year post-treatment. Then at 6 weeks and at 12 months, we would then conduct what we call a test of cure. Basically, we would do VIAC as our test of cure at 6 weeks. And at 12 months, the plan was to do both VIAC and HPV DNA testing. And cure was defined as acetonegative at, when they come for follow-up. And treatment failure was if a patient is acetopositive when they come for follow-up. And those were some of the indicators that we were assessing for tolerability, that is side effects. We would look patients who come back reporting lower abdominal pain, lower backache, bleeding, discharge, we would regard that as side effects. And then complications, severe back pain requiring parenteral analgesics, severe bleeding with clots, PID. Then, like what I said, cure was assessed at 6 months and at 12 months post-treatments. All ethical considerations were taken care of. Permission to conduct the study was done through the Institutional Review Board of the Harare City Health Directorate, and confidentiality was assured and maintained. So we go straight into our results. So for the 24-month period, 1,618 patients were done LEAP. And one of the indicators, which is the NHS SP looks at, is how many were done under local anesthesia and how many were done under general anesthesia. So 100% on that indicator, 100% of our clients were done LEAP under local anesthesia. In terms of demographic, majority of our clients attained education up to secondary level, Form 4, and majority were married. And the median parity of 2 with a lower quartile of 1 and upper quartile of 3. In terms of HIV status, majority, I think it goes in line with what was presented also yesterday. Majority of our clients, 91% were HIV positive and 99% were HIV negative. Which brings issues to do with our programming. I guess the the service should be available to all women in Zimbabwe. That is cervical cancer screening and treatment. In terms of age distribution, again, this slide and the following slide, it also advises us, especially to do with programming. We can see these are acetopositives only. It brings to issues to do. At what age should we start screening? At what age should we finish screening? You can see that majority of those who came were between 31 and 45. And the median age of the patients of our clients was 19. And in terms of age at sexual debut, the median age at sexual debut was 19. Again, bringing issues to do with programming implications. In an HIV setting, high burden HIV setting, at what age would you want to start screening? I understand there are a number of guidelines, WHO guidelines, American guidelines, European guidelines. But that's the median age of our clients. One of the indicators that is also tracked by the NHS CSP is the diagnostic to treatment interval. Recommendation is that 80% of your clients should be attended within 4 weeks. So for us, this one, we achieved it. On the left of this of that diagram are the patients that were attended within 4 weeks of presentation. So you can see that we're at 90.2% of our clients being attended within 4 weeks. Then in terms of histological outcomes, again, it's an indicator that is tracked. 58% of our clients had high-grade disease, that is CIN2+, and 37% CIN1, and the other small percentages for invasive cancer and HPV changes. Then, in terms of histological type, another also very, very important variable, we know that majority of our cervical cancer is of the squamous cell variety. But yes, we can see that in about 2%, 1% had also glandular and 1% had a mixed type, both glandular and squamous disease. Then this slide was assessing the surgical techniques of whoever was doing the lips. The best practice standards would be have clear margins, both the endocervical and the ectocervical margin when you are doing the lip. According to our findings, in 58% of our clients, the margins were clear. The endocervical margin is the more the margin that is more associated with either recurrence or persistence of disease. So we can see that in 13% there was endocervical margin involvement, and also in 10.8 there was both margins. However, clear margins for endocervix was 75.7. Then in terms of depth of excision, like what I said, the minimum depth that is recommended should be 7 millimeters. So on the right are those clients that were excised more than 7 millimeters. So our median depth, when we combined all the results, was 10 millimeters, which was quite above the minimum standard. Then in terms, again, this graph basically shows the same information, that all those that are above the red line, they surpass the 7 millimeter benchmark. Those that are below, it was below. So the target should be 85% of your excisions should exceed 7 millimeters. Then these are also incidental findings that come with some histology reports. schistosomiasis, chorioelomata, cervicitis. Those are some of the incidental findings. In terms of technique, according to the guidelines, 80% of our excisions should be done as single cut procedure. This is good specifically for the pathologist. It makes life easy for the pathologist to interpret whether the excision was complete, because if you do multiple cuts, there will be so many pieces and it will be very difficult for the pathologist to interpret the histology results. So for this one, 89% of our excisions were single pass, so we actually exceeded the target. And in terms of side effects, you can see that majority, almost 90% of our clients reported no side effects. In small percentage, about 8%, they were complaining of low abdominal pain, cramps, etc. Then in terms of complications, again, it shows that LEP is a relatively safe procedure. 99.3 reported no complications whatsoever. Then cure rate is, because we are doing this as part of just running of our clinics, you find that the patients who come back at 6 months and at 12 months, the numbers fell down drastically. But when you compare the two facilities, Edith Opperman had a cure rate of about 84%, while East Wilkins at 92%. However, the numbers that came back for the 6 months and 12 months checkups, it dropped drastically. Then cure, this one we are still working on it on the 12 months because we want to do both VIAC and HPV DNA testing to assess as a test of cure at 12 months. Then if I were to summarize our performance maybe in table format, this is how we performed. Treatments under local anesthesia, that one we exceeded the 80. So on the first column, that is the target. And on the last column, that is what we achieved. Treatments under local anesthesia, that one we did 100%. We don't do our lips under GA. Depths, more than 7 millimeters, we did 85% against a target of 95%. Percentage of removed as a single loop, we did 89% against a target of 80%. Percentage that came back from lab reporting adequate biopsy, we had 99% against a target of 90. Percentage that came with reporting high-grade histology, we had 58% against a target of 65. Then percentage treated within 4 weeks, we had 90% against a target of 80. And those who came back reporting either cancer or recurrence, this one we looked specifically for those who came reporting for cancer. We didn't have any. It must be, the target is, it must be less than 5%. And our cure rate, we performed 88% against a target of 90%. And basically this is how we do the LEP procedure. With your cut, remove, excise, and remove where there is acetyl-white lesions. Then after doing that, you coagulate to stop all the bleeder. And so, ladies and gentlemen, here's my take-home message. We feel that LEP is constitutes the workhorse for the outpatient management of ectocervical and endocervical cervical dysplasia that occupies at least 3 quadrants of the transformation zone. It's a useful and tolerable outpatient procedure which can be safely administered by trained health service providers. We noted some programming gaps which we feel that can be addressed, like as you saw that majority of our clients were HIV positive. We think screening and treatment should be available to all women in Zimbabwe. And again, the age ranges from our data sets helps also in programming in terms of age of starting screening, etc., etc. And we feel that these self-evaluations are very important by all practitioners that offer it at our health facilities in this country, because they help in self-auditing and also improve where people see that things are not waking up. I will wind up by quoting this guy, Professor Palm from Zambia. He's an American who was at the University of Lasaka. Yes, we love to screen, but the capacity to prevent cervical cancer requires more than high-performance screening tests and guidelines. Screening only does not save life. Treatment of the screen positive does. Thank you.